Thank you, Professor Wu, for the kind introduction, and I also like to thank Professor Wing Chan and the organizing committee for the privilege of speaking here. This afternoon, I thought I'll share a little on MR imaging of the bone marrow. Now, traditionally, we have assessed bone marrow by using the plain radiograph, but unfortunately, it's not a terribly sensitive modality. It is estimated that you need about 20 to 30% destruction of the bone before this can be seen on the plain radiograph, and that is in the extremities. When you have areas of complex anatomy like the spine, you find that there's a lot of superimposition of shadows, and the sensitivity of plain radiograph goes down even further. Now, in some ways, CT has mitigated this issue, but it is still not very sensitive for early marrow changes. Interestingly, another traditional imaging modality, the bone scan, is fairly sensitive for detecting early marrow changes, and it also allows us to evaluate the entire skeleton. The problem with bone scan, however, is that it is not very specific. At the opposite end of the spectrum, you can get a very specific and very sensitive diagnosis by performing biopsy, but obviously this is an invasive procedure, it's not a very comfortable procedure, and it's not something that you can do on a regular basis. So practically, MRI affords us the best modality for assessing marrow disorders. Now, accurate MR interpretation really requires a good understanding of the appearance of normal marrow. So we will spend the first part of this talk looking at the appearance of normal marrow, and then we will go on to a simple approach to classifying marrow disorders that you can perhaps use in your clinical practice. And finally, we will look at some of the challenges of marrow imaging. Now, to know the appearance of normal marrow, we really need to know what normal marrow consists of. And there are three key components. First, we have myeloid tissue. And this is the active component of the marrow. It is what divides to give you the blood cells. Next, you have the fat cells, which are these white blobs like so, within the marrow space. And finally, you have the stromal tissues in between. Now, when pathologists look at bone marrow, they really look at the myeloid component, which is the active component, and they describe it using the term cellularity. So when they say that something is highly cellular, it means that it has a high component of myeloid tissue and vice versa. Now, for radiologists, we also tend to view marrow in a similar way, although we use slightly different terms. We use the terms red marrow and yellow marrow. So red marrow is marrow that is cellular, it contains more myeloid tissue, and it is hematopoietically active marrow, and this has a high water content, giving it a low T1 and a high T2 weighted signal. Yellow marrow, on the other hand, contains more fat, so it is hematopoietically inactive, and the fat gives it a high T1 and a high T2 weighted signal. And the MR appearance of any part of the skeleton that we look at really depends on the relative amounts of these two types of marrow that are present in that particular location. So it is important to understand how this is affected by two important factors. First, the patient's age, and the other is the site that we are looking at. Now, with regard to patient's age, you find that at birth, almost 100% of the marrow comprises of red marrow, apart from pockets of yellow marrow in the epiphysis and the apophysis. With time, this converts to give you yellow marrow, such that in the normal adult, only about 40% of the marrow is made of red marrow. The conversion from red to yellow marrow occurs in a very organized manner, beginning from the periphery and then extending centrally. And this is quite well demonstrated in this diagram here. You can see that at birth, the skeleton comprises mainly red marrow, although you've got small pockets of yellow marrow in the apophysis and the epiphysis. With time, this converts to yellow marrow, and this begins in the extremities, and then it progresses more centrally like so. Within individual long bones, The changes begin first at the diaphysis, and then it extends to the distal metaphysis before finally affecting the proximal metaphysis, such that the relative distribution of red and yellow marrow in a young adult is as such. You find red marrow primarily in the axial skeleton, as well as proximal aspects of the long bone, and yellow marrow in the rest of the skeleton. So how does this impact on the normal MR appearance? Well, if you were to look at the spine in a young patient, you find that because of the high amount of red marrow that is present, it has a low T1 weighted signal, apart from small amounts of fat around the central venous plexus, like so. On the other hand, if you look at the spine in an older patient, you find that it has a high T1 weighted signal compared to a younger patient. And this difference is even more marked when you look at certain parts of the skeleton, such as the pelvis. Now, if you look at the marrow in a teenager, you can actually make out three distinct zones of marrow signal. First, if you look carefully at the epiphysis and the apophysis, as we have seen, this comprises of yellow marrow even at birth, so it has a high T1 weighted signal. Next, if you look at the spine itself, this would have a large amount of myeloid tissue or red marrow, and this gives it a low T1 weighted signal. And finally, in the areas in between, we have a mixture of red and yellow marrow, giving it an intermediate high T1 weighted signal. On the other hand, if you were to look at the marrow in an older patient, it has a more homogeneously high T1 weighted signal, like what you see here. So what is important to note is that you can have a spectrum of MR appearance for the bone marrow, all of which may be normal depending on the patient's age and the particular site that you're looking at. So with this in mind, let's go on to look at marrow pathology. Now, a large number of pathology may affect the bone marrow, and it is beyond the scope of this talk to deal with them individually. So what I propose to do is to deal with them in broad groups based on the pathophysiology. And within these broad groups of marrow disorders, we can look at some specific disorders. So what are the broad groups of marrow diseases? Well, basically, they can be divided into these 5 groups: marrow reconversion, depletion, oedema, ischemia, and infiltration. And we will look at these in order, beginning with marrow reconversion. Now, marrow reconversion basically reflects a physiological response to an increased need for more hematopoietic marrow. Now, we have seen that red marrow is the marrow that is hematopoietically active, and yellow marrow is the relatively inactive marrow. So when there is an increased need for more hematopoietic marrow, what happens is the yellow marrow converts to give you more red marrow, and this results in a decrease in the T1 weighted signal. And we can see this in various causes of chronic anemia, such as sickle cell anemia, thalassemia, or anemia of any chronic illness, including chronic renal failure. Now, you may come across the terms failure of conversion and reconversion. What is the difference? The difference is really in the time of onset of the disease. In failure of conversion, the disease begins early in life, in childhood, such that the red marrow does not convert to yellow marrow. Whereas in reconversion, the disease begins later in life, in adulthood. In this case, the red marrow has converted to yellow marrow, but in response to the increased need for more hematopoietic tissue, it then converts back to red marrow. We have seen that marrow conversion occurs in a very organized manner, and likewise, marrow reconversion also occurs in a very organized manner, but in the reverse order of marrow conversion. So as an example, in this patient, if marrow reconversion were to occur, it would first affect the spine, and it would have a low T1 weighted signal like so. If this were to progress further, it would then spread to the pelvis and the proximal femur, giving it a low T1 weighted signal. And in extreme cases, if the need for increased hematopoietic marrow were to persist, this could extend further to give you something like this, although this is quite uncommonly encountered in clinical practice. Now, this is an image of a patient with a failure of conversion. And how do you tell that this is a patient with failure of conversion? Well, if you look at the vault and compare it with a vault of a normal patient in the 40s, you find that in the normal vault, it should have a higher amount of yellow marrow, giving it a high T1 weighted signal like so. Whereas in this case, it has a lower weighted T1 weighted signal. Now, those of you who are very astute may also see another feature. In the abnormal marrow, there is expansion of the vault compared to the normal scalp. And this reflects the chronicity of the disease process. In this case, it is due to a patient with thalassemia with a classic hair on end appearance that you see on the CT. So what are the clues that you're dealing with disorders of marrow reconversion? Now, because the cause is something that is systemic, you find that in terms of the pattern of distribution, the changes tend to be diffuse and they tend to be symmetrical. The sites affected also provide a clue. As I've shown, they occur in a very organized manner, beginning first in the spine and then progressing onto the pelvis and then the proximal aspects of the long bone. So if you see abnormal marrow changes, say in the long bone, but you don't see those changes in the spine, it is quite unlikely that this is a disorder of marrow reconversion. And in chronic cases, as we've just seen, you may also encounter bone expansion. And in this day and age of electronic records, it is always useful to confirm this by looking at the clinical history or the hematological results. Next, marrow depletion. Now, we have seen that the useful component of marrow is the myeloid tissue. And in disorders of marrow depletion, basically the useful component, which is the myeloid tissue, becomes replaced by the less useful component, and that is fat. And we see this in patients post-radiotherapy, as well as in patients with aplastic anemia, and occasionally in patients post-chemotherapy. In terms of distribution, they can be segmental if it's due to radiotherapy, or diffuse if this is associated with aplastic anemia. Now, how does a patient with marrow depletion appear? Well, usually the marrow would have a high T1 weighted signal because of the larger amounts of fat within the marrow. Now, I've mentioned earlier that as patient ages, there also tends to be more yellow marrow within the skeleton. So how does this appear from a patient with marrow depletion? Well, I think this is best appreciated if you put them alongside each other. And you can see that in a patient with disorders of marrow depletion, it has a higher T1 weighted signal and it has a more homogeneous appearance compared to the marrow in a normal aging patient. Now, this is a patient with CA colon, and you can see that there are scars in the anterior abdominal wall from previous surgery. If you look at the pelvis, you can see that it has a high T1 weighted signal because it is a fairly elderly patient. But within the area of high T1 weighted signal, you can see a central aspect that has higher T1 weighted signal and it has very well-defined margins like so. And if you want to perform fat set sequences, you can see that it sets out more homogeneously. Now, why would a patient with a CA rectum get this pattern of marrow depletion? Now, this can be best explained by looking at these images. These are images that are used for radiotherapy planning. On the right-hand side, that's on using X-rays, which is what we used to do in the past. And on the left, it's using CT, which is what we tend to do nowadays. But basically, they convey the same message. The area that is exposed to the most radiation is the central aspect, and the periphery of the pelvis is actually shielded from the radiation beam. So if you were to transpose this onto the MR, you can see that you can now see why the areas of marrow depletion occur in the central aspects and there is sparing of the periphery. So what are the clues that you're dealing with disorders of marrow depletion? Well, as we have seen, they have a very homogeneous appearance and a very high T1 weighted signal. And in our clinical practice, we usually encounter them in patients post-radiotherapy. So in terms of distribution, they would tend to conform to some pattern of radiation. They would tend to conform to a radiation porter. Now, as radiologists, we are not always aware of what the radiation porters are, but basically the clue is that these tend to have a straight, well-demarcated margin. Now, marrow edema is something that you are all probably very well familiar with. And in contrast to the previous two groups of marrow disorders, this tends to be more focal. There are many causes, the most common of which is due to trauma. And classically, when it is due to trauma, it tends to involve opposing ends of the joint, and it tends to have ill-defined margins like so. Now, occasionally, when we look at the pattern of marrow edema, we can tell what the underlying etiology is. In this case, you can see some edema in the mid portion of the femoral condyle, as well as the posterior portion of the tibial condyle. And this is the classic pattern of marrow edema that we would see with an ACL tear. The ACL generally restrains the tibia from moving forward, but when it is torn, the tibia can move forward relative to the femur, and it can impact the mid portion of the femur and the posterior portion of the tibial condyle, giving the typical pattern of marrow edema. Now, this is another example where you can tell what the underlying cause is. In this case, you can see marrow edema involving the medial portion of the patellar facet as well as the lateral aspect of the femoral condyle. And again, this is quite clearly seen on the axial image. You can see the classic areas of edema involving the medial patellar facet and the lateral femoral condyle. And this is typical pattern of marrow edema that you see in a patient with transient dislocation of the patella. In this case, as the dislocated patella returns, you can see that the medial portion of the patella impacts against the lateral aspect of the femur, giving the edema in the expected locations. In many other cases, however, the presence of marrow edema doesn't tell you what the underlying cause is. In this patient with pain in the right hip, for example, you can see that there is edema in the femoral head, but this is really fairly non-specific. This can be due to trauma, it can be due to early AVN, it can even be due to tumors such as an osteoma. And in this case, it was due to a patient with bone marrow edema syndrome. So in terms of clues to diagnosis, it really depends on the cause. If it is due to trauma, you may get a relevant history, and they may tend to occur in very typical sites at opposing ends of a joint, or like the other sites that we have seen in patients with ACL tear or in transient dislocation of the patella. But if it is due to other causes, it tends to be less specific. Now, moving on to marrow ischemia, this usually manifests itself as an avascular necrosis of the subchondral bone or medullary bone infarct. And it tends to favor fatty marrow over hematopoietic marrow, possibly because of the more limited supply of blood in yellow marrow compared to red marrow. So this is the classic appearance of a patient with AVN. It tends to involve the subchondral aspect, and it has this so-called double line sign. The outer line with a low signal is due to the presence of the infected bone, and the adjacent area of high signal is due to the presence of granulation tissue. And when you see this, it is very classical and pathognomonic for patients with AVN. Although in my own experience, you don't see this as commonly as what literature reports. Literature reports seeing this in as many as 70 to 80% of cases of AVN. Now, when it involves the medulla, the key to diagnosis is really the typical serpiginous appearance that you see here. Now, you don't have to give contrast in these cases, but if you do, you may sometimes see enhancement at the margins of the lesion. And because the cause of the avascular necrosis may be something systemic, for example, the use of steroids, you may see multiple lesions, as in this patient. Now, obviously, if the AVN or the bone infarct is extensive, you can see the changes on plain radiograph, but MR is much more sensitive and specific. So the clues to diagnosis really is the appearance and the location. When it occurs in the medulla, it has a very typical serpiginous appearance, and if it manifests as avascular necrosis, it tends to involve the subchondral area, and it may give a double-line sign. And of course, it is useful to look at the history as to a possible etiology for the avascular necrosis. Now, finally, marrow infiltration. In patients with marrow infiltration, what happens is the normal tissue, either the myeloid tissue or the fat, gets replaced with pathologic tissue. There are several causes, the most common of which is metastasis and myeloma. And in terms of distribution, they can occasionally be focal, but more commonly, they tend to be diffuse. And this is the classic appearance of a patient with a marrow-infiltrated disease. You can see multiple lesions, varying shapes and sizes, randomly distributed throughout the skeleton. And when it has this classical appearance, the diagnosis is fairly obvious. What is sometimes more difficult to assess is when there is diffuse infiltration, as in this patient. And the key to making the diagnosis is to remember that in a 60-year-old patient, the marrow should have a higher signal, somewhat like this, rather than the low signal that you see here. This is more commonly seen in a younger patient, but even in a younger patient, you tend to see some fat around the central venous plexus, whereas in this case, even that is lost. Now, moving on quickly to some of the challenges that we may encounter in marrow imaging. There are a number of challenges, but I will only have time to deal quickly with 3. The first is insufficiency fractures. Now, I used to work in a cancer center, and every few months we will see patients with insufficiency fractures referred to us as having bone metastasis. Maybe this is a bit like what Erin mentioned about atelectasis adjacent to the aorta. Now, what are insufficiency fractures? Basically, they are fractures that occur when normal stress is applied on abnormal bone. And you can see them in a number of sites, but the ones that tend to be problematic are the ones that occur in the pelvis. There are various causes for insufficiency fractures. The most common is osteoporosis, but you can see that even post-irradiation can be a predisposing cause for insufficiency fractures. And that is what adds to the confusion. Now, this is a case in hand. I remember this case quite well because it was a case that I saw within my first week of starting work as a young attending at the cancer center. Now, one of the oncologists brought this case down to show me, and it was a patient with CA cervix. In fact, it was one of his relatives, and she presented with bone pain and had an MR performed outside. And if you look at the marrow, it has the typical high T1 weighted signal that you see in a post-irradiated pelvis. And if you look at these lesions, it is not surprising that these were mistaken for metastasis. They have the classic appearance in that they have a low T1 weighted signal and a high T2 weighted signal, and on a background clinical setting of known malignancy, it is understandable when these are called metastases. Now, what is the clue that this is not bony metastasis? The key really is in the distribution of the lesion along the sacral ala. This is a very common site for insufficiency fracture, and it is also uncommon for metastasis to be symmetrical, as in this case. And being an oncologic patient, she had a recent CT, and if you look at the CT, what you see is a bit of sclerosis, like so, which is in keeping with insufficiency fracture. But of course, being a relative of an oncologist, she had the full works, so they did a bone scan for her, and on the bone scan, you can see the classic pattern of increased uptake in sacral insufficiency fractures. Got the increased uptake along both parts of the sacroiliac with a horizontal component across. Usually this is around the level of S2 or 3, and this is the classic Honda sign. Now, obviously, it's fairly easy to recognize this if it has a classical appearance, but in life, not all things occur in a typical manner. If you have insufficiency fractures that affect only one part of the sacroiliac, the diagnosis may be a bit more challenging, but if you look at it carefully, you can still make the distinction. In patients with insufficiency fractures, the signal abnormality tend to have a more linear appearance like so, and not infrequently, they are associated with insufficiency fractures elsewhere in the pelvis, classically along the pubic symphysis or the pubic ramus, as in this case. On the other hand, if you have metastasis to the sacroiliac, they have a slightly different appearance. They tend to be more discrete and mass-like, as in this patient, and occasionally you can see frank bone expansion or bone destruction. Now, post-treatment changes can also pose some diagnostic challenges, and the post-treatment change that I want to talk about is post-GCSF treatment. Now, GCSF, or granulocyte colony stimulating factor, is something that oncologists often give as an adjunct to chemotherapy. And what is the function of GCSF? Well, basically, it stimulates the formation of blood cells, it moderates the degree of neutropenia, and it reduces the chances of infection in patients on chemotherapy. But if you think about it, what it really does is it causes marrow reconversion. And this may sometimes be confused with an infiltrative process if you're not aware of this condition. Now, this is a case in hand. This is the MR spine. This is the marrow appearance in a patient post GCSF treatment. And this is the same patient a couple of weeks after GCSF treatment. And you can see how this can sometimes be confused with an infiltrative process or metastasis. What is the key to making the diagnosis? Well, one is, of course, to be given the clinical information. I don't know about clinicians in Taiwan, but certainly in Singapore, we rarely get such useful information. But the other bits that may give you a clue to the diagnosis is to look at the site of involvement. As we have mentioned, with patients with marrow reconversion, usually they occur in very specific sites along the spine, the pelvis, or the proximal aspects of the long bone. The other clue really is the time course to the changes. Because GCSF has a limited span of action, you find that the changes will generally not occur beyond a 6 to 8 weeks lifespan. So if you see changes more than a few weeks after GCSF treatment, it is unlikely to be due to post-GCSF treatment. Now, you don't normally need to do a PET or a bone scan in these patients, but as I've said, in oncologic patients, they may have these scans for other reasons. And if they do, and if you look at the scans, you find that for bone scans, they are usually unremarkable, or in PET scan, you may just have very diffuse marrow hyperplasia and no localized lesions. Now, the other diagnostic challenge is in patients with multiple pathology. And this may seem a bit ironical because MR is good for telling us the presence of multiple pathology. This is an example, fairly typical. Elderly patient who comes in after a fall, complains of back pain, and you can see there are some fractures like so. And usually MR is requested to distinguish the cause of the fractures. In this case, you can see that the patient has got metastasis, but there are also old compression fractures. But occasionally, it is not as simple to make the distinction in a patient with multiple pathology. And this is an example. It's a patient with lymphoma in remission who presented to us with back pain as well as shoulder pain. You can see multiple lesions within the spine. And if, although it's uncommon, if you look at the appearance of the lesion, you can see that these are multiple bone infarcts within the spine. And if you look at the shoulder, again, there are multiple sites of bone infarcts, like so. What was uncommon was this lesion in the proximal humerus, and we thought that this could be due to early bone infarct, where you get bone edema as a manifestation. But because the patient's pain was persistent, they went on to do a PET scan. And on the PET, this area showed marked increased uptake. There were uptakes in the other sites as well, but they had much lower uptake, and they proceeded to a biopsy, and this turned out to be a focus on lymphomatous infiltrate. And it's not always easy, therefore, to distinguish when patients have multiple pathology. Now, this is an elderly patient who fell and complained of hip pain and had an MR done to exclude a hip fracture because the plain radiograph was unremarkable. And the fellow who was reporting this was quite happy because he thought he had found the cause of the hip pain. You can see that the patient has got multiple metastases. But if he had looked harder, he would have seen the cause of it. Right? In this case, what he did not see was the presence of a large lesion in the prostate. There was extracapsular involvement infiltrating the bladder base, as well as resulting in left hydroureter, like so. And this was in a patient with a prostatic carcinoma with bone metastasis. So this is just a reminder to look beyond the skeleton and to look for other pathology. So I will just quickly show you a couple of quiz cases. Right? This is a patient with a known malignancy, presented with back pain, and had an MRI done to look for bone metastasis. Now, which category of marrow disorder would this fall into? All right. Now, I think what we can exclude first is marrow infiltration. If you look at the marrow, it's fairly unremarkable. The other thing that we can exclude is marrow reconversion. As we have seen in patients with marrow reconversion, it would have more red marrow, and it would have a low T1 weighted signal in the spine rather than the high T1 weighted signal here. So the question is really, is this normal, or does this show changes of marrow depletion? Now, if you look very carefully, there is a slight change in the marrow signal above and below the L45 area. And this is particularly obvious in the fat set sequences like so. So this is a patient with marrow depletion. Now, why would patients get this pattern of marrow depletion? Well, if you speak to your radiation oncology colleagues, you find that for pelvic malignancies, the upper level of irradiation is usually at the L45 level. So if you look for it carefully, you can actually see the changes in this patient. Now, this is a 5-year-old patient who presented with shoulder pain and anemia. And again, the question is, what is the cause in this patient? Right. I think the first thing you can exclude is marrow depletion, right? I'm unlikely to show you 2 cases of that in a row. But seriously, in patients with marrow depletion, it would have a high T1 weighted signal because of the presence of fat within the marrow. And in this case, you don't see the high T1 weighted signal. And now the other thing is, can this be normal marrow or marrow conversion? Well, if you remember what we mentioned earlier, in a young patient, the marrow would have a low T1 weighted signal, and likewise in patients with marrow reconversion, it would also have a low T1 weighted signal. So you can actually exclude those through exclusion. Now, what is the feature that there is marrow infiltration in this particular patient? Again, if you remember what we discussed earlier on, In the epiphysis, you tend to see fat you tend to see yellow marrow even at birth. And in this particular patient, you can see that the fat in the epiphysis is gone, and this is a feature of marrow infiltrative disease. So in conclusion, MR is probably the best modality we have for assessing marrow disorders. But before you even look at the MR, you can glean a lot of useful information by looking at the patient's profile, by knowing the age in the particular site that you're looking at, and by having a mental picture of what the normal appearance of the marrow should be in these patients. And of course, a good clinical history would be useful. When looking at marrow disorders, it may sometimes be useful to think in broad groups of pathology before you home in on the specific disorders. And finally, do be aware of some of the diagnostic pitfalls so that you can avoid them. So thank you very much for your attention.
Thank you. Thank you for Professor Kreckner, excellent lectures. Any questions from the audience? Any questions? We can have time to have one or two questions. Well, the time is a little delayed. Okay. Professor Kreckner, you have mentioned about this path sequence. I am concerned with a path sequence first. So a T1 is most recommended.
Yeah, I think for me, I like to use T1 as well as FAT-SET sequences. T1 is particularly useful in older patients because the marrow in those patients would have a high T1 weighted signal, whereas most pathology would have a low T1 weighted signal. FAT-SET, the FAT-suppressed sequences are also useful. In terms of contrast, I don't usually use contrast if we are looking at the marrow itself, but it may be useful if we are looking at soft tissue. In terms of contrast, I've seen metastasis enhanced with contrast, and then it looks relatively normal in some of these cases.
Do you have recommend some any special sequence for we can see better? Such as,
well, we have tried diffusion-weighted sequences, but we have not been terribly impressed with the results. We tried line diffusion images in the early days, but the quality was not as great as we hoped for. And there's always overlap with infection and other issues.
How about in and out of the face sequence? Have you tried it?
We have done that for some patients to really look for the fat within that, but we do not do that on a routine basis.
Yes.
What about you? Do you do that regularly?
We can't use it as a routine, just
yes.
As your comment. Yeah.
We use it in our case just for all our therapy. Because what you can see dropout out of it very, very specific. So typically we use in and out phase a lot when we're looking for marrow lesions. Because as you pointed out, that there's always fat even in the ones that have red marrow, because they still have about 40% fat, whereas the other ones have 80 in the fatty lesions. So if you do in and out of phase imaging and there's dropout, you know that that area, even though it's abnormal in the T1, contains some fat, and that could tell you that it's normal. So whenever we have trouble cases, we actually do in and out of phase imaging on all our tumor protocols. And if you don't have contrast, you can just do in and out of phase imaging, and that can be quite helpful.
Okay, thank you, Dr. Wu's comment. Any question? And may I have another?
Yeah, sure.
Okay. The last question is the practical situation. Such in the spine region in the vertebra, there's a high signal change. such as maybe it's due to bone marrow edema. Maybe it's due to bone tumor inside, such as metastasis. And sometimes we have the experience. It's not very easy to differentiate this situation. Do you have some comments? It's a bone marrow edema or bone metastasis, for example, in the vertebra. It's all high signal.
Sure.
Yeah.
I guess for one, we will try to look for the features that may point to metastasis, whether it's a more discrete lesion, whether it extends to the posterior elements, and but you're quite right in that in some cases it's actually hard to tell. For example, the case of the marrow edema in the femoral head, it is very non-specific. As I've said, marrow edema in itself is a non-specific feature. It just tells you that there's an abnormality there. And, usually for these cases, sometimes we may perform a follow-up scan just to see what happens to it and to look at the natural evolution. But usually for these, we will also discuss with the clinician in terms of the clinical suspicion.
Do you perform the bone biopsy frequently in your hospital?
We do some biopsies, but it really depends on the clinical indication, whether there is a need to go in, because you can also get false negative biopsies.
Okay, any further questions? Okay.
Thank you.
Thank you, Dr. Craig, Professor Craig, for your excellent lectures.